I'm welcoming you all in this advanced cardiac pacing course by AFRA in 2025. At AFRA, we are very proud with this course with such a distinguished faculty of speakers and a rich agenda of topics meeting your expectations as advanced electrophysiologists and device implanters. I'll start right away with this very first presentation of the course. A short review on the concept of cardiac resynchronization, patient selection, and guidelines review. Of course, the patient selection is one of the cornerstones for a good response to a cardiac resynchronization therapy. So let's start with this concept. Approximately 30 to 40% of heart failure patients presents with inter or intraventricular conduction delays. And this ventricular electrical dyssynchrony leads to a structural and mechanical impairment, more workload and stress compromising the LV mechanics. And the idea is to reverse this dysynchronization, reverse remodeling, which will modify the electrical activity and hence restore the synchrony between the right and left ventricle, improve symptoms and quality of life. And of course, it's a complement to the optimal medical therapy. It's a concept that has been first proposed in 1986 and have proven efficacy compared to optimal pharmacological therapy. CRT can improve ejection fraction, the NIHA functional class, the 6-minute walk test, and reduce rates of cardiac and heart failure hospitalization. And when compared to traditional ICD, the CRT decreases hospitalization and reduces the risk of death. This has been validated in a variety of trials, the MOSTEC, the Companion, the CARE-HF, the MADIT CRT, Reverse, RAFT, and many others that have studied mild forms, moderate, and severe forms of HFrEF and have shown this good outcome and impact on HFrEF patients. So what about patient selection? We know that heart failure patient presents like 50% with heart failure with preserved ejection fraction and 50% with heart failure with reduced ejection fraction less than 40%. Among these 50%, 35% presents with interventricular conduction delay with a QRS of more than 120 or 130 milliseconds. From these, like 30% represent with left bundle branch block. And like 50% of HFrEF patient presents with some sort of AV conduction delay, which furthermore impairs the synchrony and can lead to more LV mechanical dyssynchrony. And it's these 30% of patients with left bundle branch block morphology that remains the subset of patients with the highest level of recommendation and strongest level of evidence to improve and to respond to CRT treatment. This is shown in real registries like the Swedish heart failure registry that have shown that like 35% or 30 to 35% of HFrEF patients had the indication of CRT. Unfortunately, only 1/3 have received CRT implantation from those who were indicated for the CRT. If we can unmute, please. If you can mute Ali, please. The same has been shown in the ESC heart failure review registry that 35% of patients had indication according to the guidelines of class 1A or 2A, and only less than half of these patients were implanted despite the strong recommendation of their indication. So the recommendation for CRT are based on the result of major RCTs and mainly for those HFrEF patients, like 60% of patients who present with sinus optimal milliseconds, and mainly those, as we said, who represent and shows left bundle branch morphology, block morphology. Other smaller groups for the AF patients. These patients are also indicated when they have a NIHA class 3 and 4, provided that a strategy to ensure biventricular capture is in place, or these patients are expected to return to sinus rhythm. Occasionally, another indication is an upgrade from a conventional pacemaker when patients develop worsening of heart failure induced by the pacemaker with a high rate of RV ventricular pacing. These indications and recommendations have yielded this type of epidemiology. Like in the USA, we have this epidemiology of almost 10 years. Estimated CRT-D implantation was more than 378,000 implementation in the 10 years, like 40,000 devices per year, or roughly 135 patients per million per year. The number increases in Europe with more than 400 patients per million population per year. In the Sweden registry, a recent survey of 12,000 HFrEF patients showed that 30% of the patients were indicated, and as we said, only 7% of this 30% were really implanted, and the other 24% had the indication but not received. These data highlight the underuse of CRT in many of the real-world registries. What are the guidelines saying about the patient selection? And let's see the latest ESC guidelines in 2021 on cardiac pacing and cardiac resynchronization. As we said, the main morphology of patient and the subset of patients that would be indicated with the highest level of recommendation and evidence, 1A, are those who are symptomatic, regardless of the NIHA class without specification, LV ejection fraction less than 35%, a QRS duration of more than 150 milliseconds, so a wide QRS more than 150, and a left bundle branch QRS morphology. With no doubt, these patients would benefit if they are still symptomatic despite the optimal medical therapy. CRT should be considered in a smaller subset of patients who have the same criteria of left bundle branch block morphology in their QRS, but with a less wider QRS duration of 130 to less than 150 milliseconds. This indication is a should consider and not a must consider as the first one. CRT should also be considered for patients who have non-left bundle QRS morphology, especially with those who have a wide QRS with more than 150 milliseconds, and this is a 2A, should be considered recommendation. For those who have less wider QRS and non-left bundle branch morphology, they have a class of recommendation of 2B, so it may be considered for them to be implanted with a CRT if they are still symptomatic despite optimum medical therapy. Another important indication are, as we said, the patient who have less than 40% ejection fraction, so they are by definition having heart failure with reduced ejection fraction, regardless of their NIHA class, who have an indication for ventricular pacing with a high degree of AV block in order to reduce morbidity and further decline in their LV ejection fraction with a high incidence of RV pacing more than 40%. Patients who have received a conventional pacemaker and have shown significant proportion of RV pacing and have started to be symptomatic with an ejection fraction less than 35% are also indicated with a class 2A indication, so should be considered for an upgrade to CRT. What about patients with AF? For these patients, it's a class 2A. We should consider implantation of CRT if the NIHA class is 3 to 4. So not only symptomatic, but you have to evaluate their NIHA functional class, and you have to provide a strategy to ensure biventricular capture is in place, either by significant rhythm or rate control by pharmacological treatment or by AV junction ablation in order to make sure that there will be a response with cardiac resynchronization therapy. And this class of recommendation is 2A. So for the management of these patients with AF, controlled heart rate, well and good. He is a candidate for CRT because he has an ejection fraction less than 35%. He has a wide QRS more than 130, and he is still symptomatic. Go for biventricular pacing if he has a percentage of 90 to 95, especially more than 95% of biventricular pacing, you have achieved your goal. If not, then AV junctional ablation in order to improve response to CRT. If the heart rate is not controlled from the beginning and the patient has the criteria and is still symptomatic, you should start with AV junctional ablation and simultaneously an CRT device implantation in order to improve patient symptoms and improve outcome and mortality. Yet in 2025, it's not only about CRT. Is it CRT-P or CRT-D? So should you include a defibrillator during your implantation or not? And this question maybe is answered in the guidelines in a simple way. Of course, the simple part would be if the patient is already having an indication for an ICD, especially if it's a secondary prevention, and he has the CRT indication, of course, it's a class 1A to implant an CRT-D rather than a CRT-P in this patient, because he already has a strong indication for his ICD. But those who are candidate for a CRT may consider to put a CRT-D instead as a class 2A indication. And let's see why this is a lesser level of indication for those who have a full picture of CRT indication, but not quite the D or the defibrillator indication. Of course, the mortality benefit of CRT-D over CRT-P is still unclear because we don't have a head-to-head studies to show with a significance or evident mortality or outcome improvement. While it's logic, but also we have to say that CRT-D may further have its own risks with add-on lead failure risk, with add-on inappropriate shock risk, as well as the cost. Maybe the companion study was one of the few trials who have randomized patients to CRT-P versus CRT-D, but it was designed mainly to assess the effect of CRT compared to optimal medical therapy rather than to compare the two technologies or the two devices. CRT-P was associated with a marginally non-significant reduction in the risk of all-cause mortality. And when we had an analysis of cause-specific mortality, it showed in the companion that the sudden cardiac death was significantly reduced by the CRT-D with a p-value of 0.02, but not the CRT-P. On the other hand, the CARE heart failure extension study proved that CRT-P alone, and not with a defibrillator, could reduce the risk of dying suddenly or the sudden cardiac death by or more than 5%, and that was related to extent of reverse LV remodeling with the CRT itself and the resynchronization therapy itself rather than the defibrillation. Another trial was a significant trial of a meta-analysis of 13 randomized trials with more than 12,000 patients, found that CRT-D reduced total mortality by almost 20% compared with CRT. However, this difference was not found in patients with non-ischemic cardiomyopathy. It was unique for those with ischemic cardiomyopathy. on the extreme, the Danish study with more than 1,100 patients showed that in non-ischemic cardiomyopathy, there were no superior mortality suppression or prevention in patients having a CRT-D versus those who had a CRTP. So the mortality rate or the prevention was the same in the two subsets. One of the main trials who had tried to answer this was the RESET CRT project, which was mainly not a true clinical trial, but a health claims database, showed that CRTP treatment was not inferior to CRTD in terms of survival. The CRTD might be of more importance and evidence and significance in mild form of heart failure or in young population, because these patients are more at risk for sudden cardiac death mortality rather than pump failure and hospitalization mortality. Of course, we can help or guide our decision by assessing and re-stratifying our patients for their ventricular arrhythmia burden using CMR-guided scar characterization. In conclusion, prospective randomized trials are lacking and available data are insufficient to firmly prove a superiority of CRTD over CRTP. The guidelines, the European guidelines, have given us some guidance in that matter. The more the patient is older, the more he has short life expectancy. If it's non-ischemic cardiomyopathy, major comorbidities, poor renal function, the more convenient is a CRTP implantation. The younger the patient, the more the myocardial fibrosis on CMR, the ischemic cardiomyopathy, the better is to implant a CRTD for the patients. As I said, in 2025, it's more and more selection and more questions to answers before implanting patients. So yes, cardiac resynchronization, using biventricular pacing versus the new era of the conductive system pacing. And maybe one of the best papers or evidence we have from the guidelines of the 2023 from HRS, APHRS, and the Latin American HRS that issued these guidelines on cardiac physiological pacing for the avoidance of heart failure. So in this graph, you can see in patients with LV ejection fraction less than 35%, we have a clear indication for biventricular pacing. As we said, FG less than 35 Fs and data in order to have a plus 1A indication for ventricular pacing. The same goes for the second evident indication for CRT with biventricular pacing in those patients with ischemic cardiomyopathy with cardiomyopathy induced by the myopathy. They have a clear indication to go for biventricular pacing as the way for cardiac resynchronization. In other less evident indication or less level of recommendation evidence for biventricular pacing, like those with non-left bundle morphology, we can go with either biventricular or high conductive system pacing. Yet, as you can see, the zone is starting to be between the two technologies, the two concepts of achieving cardiac resynchronization, with more and more data about conductive system pacing and more experience and learning curve of the potential of this technique. We have more indication for using this conductive system pacing method as a better way for cardiac resynchronization. So the guidelines said in left bundle branch block morphology, it's evident class 1A for NIA class 2 to 4 to have a biventricular pacing. And you should consider conductive system pacing if effective CRT cannot be achieved. It's a class 2B, so you may consider biventricular pacing in patients with less indication or less symptoms, like those who have NIHA class 1, not 2 and 4, but having an ejection fraction less than 30%. So these have a 2B indication. The same goes as a 2B indication for those having an ejection fraction of more than 35, less than 50, in a sinus rhythm showing left bundle branch morphology with a duration of more than 150, and CPP may be considered to maintain and improve the LV ejection fraction. Finally, the same goes that if the patient had difficulty, or you want to have an alternate method for cardiac resynchronization and biventricular pacing, you can go from the start with a conductive system pacing, but it's a less level of recommendation of 2B. It's interesting to say that also in these guidelines in 2023, it's one of the first time we have a clear sub-selection and characterization of our patients. For example, female patients with a less rigid duration of QRS, so it's 120 to 149, so less than 150 milliseconds, they still, and if they have a left bundle morphology, they still have a class 1A indication for a CRT biventricular pacing. And the idea here is because we know that female sex and in the female gender, they have better response to CRT. And this graph might show us and explain to us that the more the height, the less the height is, and the less is the response to the QRS duration. The light blue here shows the good response to CRT, and the less is the height of the individual or the patient you are implanting, the more he will be responding even with narrower QRS. So that's why in these guidelines, even with a 120 millisecond to up to 150, you have a strong recommendation if you have the left bundle branch morphology and still the patient is symptomatic with an ejection fraction less than 35 despite optimal medical therapy. What about the non-left bundle branch block morphology and the indication of biventricular versus conductive system pacing? It's a class 2A for those who have a non-left bundle pattern, but a duration of very wide complex with more than 150 milliseconds. And you may consider conductive system pacing if the patient is ineffective to have a biventricular, or it was not possible for implantation, and you can start it from the beginning, but with a less a strong level of recommendation of 2B instead of 2A. The same goes for ejection fraction more than 35%. And we have a clear indication of 2A for those who have an anticipated substantial ventricular pacing and have an indication for pacemaker, even an ejection fraction less than 50%, you can go from the start with a CRT, the same level of evidence and the recommendation for going with conductive system pacing. So you have either ways to choose. If your patient has an ejection fraction, a starting point of more than 35%, less than 50%, and he has an anticipated substantial ventricular pacing considered. Another question in the patient selection in 2025 you should be answering, and we will answer it very briefly because we will have other presentations during our course to answer it. So if it's a conductive system pacing, would it be His bundle branch pacing or His pacing or left bundle branch area pacing? And the answer will be answered in details later, but given the limits of His bundle pacing for left bundle branch correction, we know the difficult technique, the high threshold of pacing, the rapid draining of the batteries. Pacing the more distal conductive system, the left bundle branch area, may provide an alternative mean of effective LV resynchronization. And many studies have answered this question, and one of these is the left bundle collaborative study group that showed that we have a success rate of more than 85%, and it shows a low and stable pacing threshold and good clinical and echocardiographical outcome at 6 months. So more and more left bundle area pacing rather than His bundle pacing. That said, we have maybe to have some words about other techniques that have gained some popularity a few years ago, and now, same as for the His bundle, is going a little bit less popular, is the hot CRT, or the optimization of the resynchronization using a lead in the His for pacing with the CRT and with the CS pacing. Again, in CRT candidates with left bundle branch block, biventricular pacing has more solid evidence and efficacy and safety, and therefore remain the first-line therapy. A His bundle pacing could be a bailout solution in case of failure of LV failed implantation, could be a way of thinking in patients with known to have less response to the conventional biventricular pacing like those with non-left bundle branch block morphology. And it could be also a way of thinking in patients with permanent AF, since you have a vacant atrial port that you can use it for the His bundle pacing or the left bundle area pacing. So in order to have and offer additional therapeutic option for these patients. And in the guidelines, we have some list of advantages and disadvantages of thinking this way, yet it's a word to say so that we be familiar with the idea of an assisted or optimized technique for the CRT using an additional His or left bundle area pace. My final concept in this presentation is that despite the good patient selection, we are always waiting for the response. So the response beyond the selection. Despite a good selection, we know that we have like 20 to 30% of patients that would not respond well and will need further and more supportive maneuvers in order to improve their outcome. And we will have a dedicated session for that. But in big words, we are looking for the ECG modification in order to evaluate the response to the CRT. We are looking to the echocardiographic parameters, like the reduction in the left ventricular end systolic volume of greater than or equal to 15%, or an improvement in the left ventricular ejection fraction of greater than 5 to 10%. Cardiac biomarkers, improvement of proBNP, for example, novel cardiac biomarkers like the soluble ST2 or the galactose-3. But the most important is the functional assessment, the patient symptomatology, the prevention of rehospitalization, either by clinical assessment or using quality of life scores. There are many reasons why after your good selection of patients, your patient might not show the good response to CRT, the suboptimal programming, the arrhythmia, the high burden of PVCs leading to less than 90% biventricular pacing, concomitant anemia, suboptimal medical therapy, persistent mechanical dyssynchrony, primary RV dysfunction. So we have many causes that we can tackle. Some of them are reversible, and sometimes we are guided with echo-guided CRT programming or optimization and other maneuvers. It's always good to think that yes, these are the four pillars of a good response to CRT. The very important is a patient selection, as we said from the start, to start by a good selection of your patient that he would respond to this cardiac resynchronization therapy, the lead placement during the implantation, the timing and the programming itself during implantation, after implantation, and on the follow-up to customize and personalize the programming and the parameters for your patient. You might also activate some automatic optimization algorithms offered by the different companies, and that also we will discuss it in the next sessions. And of course, the optimized medications. My take-home message, CRT, despite its proven efficacy, is still underutilized. The organization of referral system for heart failure with reduced ejection fraction patient and to have these patients with potential indication for CRT screened and follow up in qualified centers is very important. The evolution of the conductive system pacing in recent years has made the decision of CRT varying from conventional biventricular pacing to left bundle branch area pacing with less focus on the His bundle pacing, yet still more rigid data is awaited regarding long-term follow-up for these patients, the management of infection and lead extraction for these patients, especially in patients having a left bundle area paced. And thank you very much.